So we'll move into next session, session 2 on narrow QRS tachycardia. I would like to invite the chairpersons, Dr. Ilamaran sir, Dr. Pratap Kumar sir, Dr. Joy Thomas sir, and Dr. Karthikesan sir. Please occupy the dais.
Good morning. Happy to be here at the 7th edition of Tamil Nadu EPIC, conducted by Dr. Muralidharan and Dr. Jayashankar. Now we are coming to session 2, which is on narrow QRS tachycardia. May I invite the first speaker, Dr. Yogesh Kulkarni, to deliver his talk on ECG in supraventricular tachycardia.
I would like to invite Dr. Yogesh Kulkarni sir, who is a senior resident in Christian Medical College, Vellore, and his areas of interest is in cardiac electrophysiology. Over to you, sir, on ECG in supraventricular tachycardia.
So initially I am very much thankful to organizers to give me this opportunity. So my talk is on ECG in supraventricular tachycardia. So here my restricting my talk to narrow QRS regular tachycardias. So directly coming to the main discussion. So how to what are the steps to diagnose by seeing an ECG, the coming to the accurate diagnosis. So first step is the close inspection of the tachycardia ECG, then comparison of that tachycardia ECG with the sinus rhythm ECG, and if we have available any Holter tracings or any ECG which is showing the onset or offset of the tachycardia, then that will be very much useful in coming to diagnosis. So when we see a tachycardia ECG, the parameters which we will see is, first thing is any P waves are visible or not. If P waves are visible, then we are going to see what is the AV ratio, what is the PR and RP intervals, is there any pseudo S or pseudo R wave we can see in that, then what is the P wave morphology, and is there any presence of QRS alterance and ST depression. So if you see this ECG, so I can't find out any visible P waves in this ECG. So it is a regular narrow complex ECG. So most probably the P waves get buried into the QRS complex. So in this type of ECG, the probable diagnosis will be AV and RT because the P waves are not clearly seen. But there can be an atrial tachycardia with a prolonged PR interval. In that case also, the P waves get buried into the QRS complex. So what are the steps we can get those P wave out of the QRS complex? So first thing, we can give adenosine, which can either in case of atrial tachycardias we can get a P waves, or we can give a different vagal maneuvers like carotid sinus massage and we slow down the AV conduction and get the P waves. Another thing is ECG with double standardization. So like a 10 mm per millivolt to we can increase to 20 mm per millivolt and we can get an ECG. So if you see here, the P waves in initial thing we can't see any P waves in lead 1, but if you see in after double standardization we can see a good P waves are seen with a negative polarity. And fourth thing we can try is the Lewis lead. So if when P waves are visible, we can see the AV ratio. So in this ECG, which is also a regular narrow complex tachycardia, and we see there are 2 P waves per QRS complex, which is clearly seen in lead V1. So when we see 2 P waves, like AV ratio is more than 1:1, then almost the AV RT is ruled out because there is the VA relationship should be 1:1. Now what are the possibilities? Then it can be an atrial tachycardia, atrial flutter, or it can be AV and RT also, where the infranodal conduction block will be there, which is causing this 2:1 AV ratio. Then second thing we can see is in the RP interval. So again this is a narrow complex tachycardia, and we can see very good P waves in lead V4. So here we see the RP interval is anyway greater than the PR interval. So it is a long RP tachycardia. Then what are the possibilities in a long RP regular narrow complex tachycardia? So it can be an AT, it can be an atypical AV and RT, or it can be a decrementally conducting pathway. But if we see in lead 2, 3 and AVF, there are very negative polarity T waves with a pointed T waves. So most probably the P wave is get buried into this negative T waves, and due to why these T waves become prominent, and as there is in inferior leads the P waves are negative, so it generally suggests it is retrogradely conducting, or it is a most probably it is AVNRT. So this patient, when we taken for a EP study and ablation, we found out it is an atypical AVNRT. So this is another ECG, again a regular narrow complex tachycardia. I tried to find out any P waves here, but I didn't find out. So I compared this ECG with a sinus rhythm ECG, and what I saw is in the lead V1 in tachycardia ECG there is some R prime is there, which is not seen in lead V1, as well as the lead 2-3 AVF, the S waves become more prominent than the S waves in sinus rhythm ECG. So it shows that there is a presence of pseudo R and pseudo S waves in this tachycardia ECG, which is very much sensitive and specific. That is, pseudo R is very much sensitive and pseudo S is almost 100% specific for AVNRT, which is shown in the previous studies. So what is the next step we can see is the P wave morphology. So here again a narrow complex tachycardia, which is P waves are very much properly seen in lead 2-3 AVF and V4, V5, V6, and it is a long RP tachycardia. So again our probable differentials will come like a typical AVNRT, decrementally conducting pathway, or AT. Now if you see in lead 2-3 AVF, the P wave is positive. As the P wave is positive, the diagnosis of AVNRT becomes very much unfavorable. So the two diagnosis remains is either it is an AT or it is a decrementally conducting pathway. Now if you see at the initial part of this tachycardia ECG, the first two beats are sinus beats, and another from the third beat tachycardia has been started, and the tachycardia P wave is almost similar to the initial P wave is almost similar to the next P wave. So if initial P wave is almost similar to the tachycardia P wave, it is most favorable for an atrial tachycardia, and which then we proved it with the EP study and ablation of this patient. Another ECG, also a regular narrow complex tachycardia. Again this is very good P waves are seen in lead V1 and those are negative. So it is a long RP tachycardia, and again our differentials will come typical AVNRT, AT, or a pathway. So but here if you see in lead 2-3, as lead 1 is showing good P waves, but lead 2-3 AVF almost like isoelectric P waves are seen, and the lead 1 is showing negative P waves. So if lead 1 is showing negative P waves, it shows that the atrial activation is happening from left to right. So if atrial activation is happening from left to right, so it can be an AT which is coming from left side, or it can be a left lateral pathway. So negative P wave in lead 1 is one of it suggests that it can be a left sided pathway. The another important thing we can see is the QRS alternance. So again the same thing, it is a regular narrow complex tachycardia with continuously changing QRS amplitudes. So QRS amplitude during the tachycardia changes because of there is a oscillations in the refractory periods of the conduction system, as well as there is a change in the action potential durations. So this QRS alternance is depend upon the type and rate of the tachycardia, but most probably it favors AVRT. So here again we can see small humps of P waves on the PR interval, ST segment, and if you see properly the RP interval is more than 70 milliseconds. So almost it is unfavorable for an AVNRT, and we can see negative P waves in the lead 1. So again it can favor AT, or as there is a QRS alternance, it favors pathway conduction. Now this is another ECG, narrow complex tachycardia. Again here I can't see any P waves, but the most striking feature I have seen here is the ST depression. Almost 4 to 5 mm ST depression is seen in lead 2-3 AVF as well as V4, V5, V6. So this ST depression is most probably because of a longer VA conduction and the longer atrial activation time, which is gets superimposed on the ST segment. So this ST depression, so more than 2 mm ST depression, it favors the AVRT. So when we reverted this patient to sinus rhythm, it showed that a prominent R in V1 as well as almost a isoelectric or negative delta in lead 1 suggestive of left sided pathway. Now coming from the tachycardia ECG, when come to a sinus rhythm ECG, the manifest pre-excitation, if we see on a sinus rhythm ECG and a patient is presenting with a narrow complex tachycardia, most probably it is a AVRT. Rarely we can find sometimes a patient presenting with a regular narrow complex tachycardia and there is a dual AV nodal physiology on the ECG. So this is a one Holter strip which the patient we done for one patient, and if you see the initial part of this sinus rhythm, the PR interval is almost like 360 millisecond, and the latter part the PR is suddenly shortened. So it shows that like the conduction is shifting from the slow pathway to the fast pathway, showing a dual AV nodal physiology, and it suggests AVNRT. Then the last part of this thing is the initiation and termination. In this ECG, if you see, initial part is sinus rhythm, then there is one atrial ectopic is coming, conducting with a prolonged PR, and the tachycardia starting. So an atrial ectopic with conducting with a prolonged PR, starting a tachycardia suggests AVNRT. Then termination. If any tachycardia terminating with a P, then unlikely it is AT, because the firing focus is stopping as well as AV node is stopping at the same time, it is very unlikely. But if it is terminating with the QRS, then it can be anything. Like in this ECG, initial part is, you can see the tachycardia is there, and at present this is the tachycardia is ending. Then the if there is a initiating P wave is same as tachycardia P wave that we can see here, that we already discussed, and warm up and cool down phenomena can suggest you of ET. So what is the take home message is, finding the P wave is the most critical step in the diagnosis of narrow complex tachycardia. Adenosine vagal maneuvers, ECG with double standardization and Levis lead will help in diagnosis. Sinus rhythm ECG, Holter showing initiation termination are immensely useful, but the most criteria will give a probable diagnosis, but EP study is the conclusive one. So we should always be ready to get surprised in the EP lab for when we are doing ablation. Thank you.
Thank you, sir, for the extensive talk. We would like to invite the next speaker, Dr. Anand sir, who is an associate professor of Christian Medical College, Vellore, and his special areas of interest are complex atrial flutter ablation, channelopathies. A warm welcome to you, sir.
Good morning, everyone. At the outset, I thank the organizers of TNEPIC for giving me this opportunity. My talk is on EP maneuvers in SVT. Can you get the slides on? So, when coming to EP maneuvers in SVT, before going to the maneuvers, there are basic EP features already discussed by Dr. Saktivel, like dual AV nodal physiology on baseline antigrade study, AV nodal echo beats, then pre-excitation on ECG on pacing, retrograde study showing a concentric or concentric atrial activation or a eccentric atrial activation, all will be helpful. And in the EP lab, features of SVT, what is the VA relationship, what is the VA interval, where if the tachycardia terminates, where it terminates with the PR QRS, or if the what is the bundle branch, if there is a bundle branch block during the SVT, what is there any change in the tachycardia cycle, and always help in deciding what is the mechanism of the tachycardia. So 80% of the diagnosis can be get from the initial baseline EP study, and also during that what are the features of SVT. Then I'm coming to the pacing maneuvers during the tachycardia. Most commonly we use is the ventricular overdrive pacing and the His refractive PVC. In my talk, I'll talk only about VOP. So the DD is important, comes to play. We have what is the mechanism when there is a tachycardia with a concentric atrial activation when the VA interval is more than 70 milliseconds. So for this, all these three DDs are present. One is the AVNRT, and is AVRT. Here I can show a diagram with actually right side axis which is slightly lateral, but actually which is septal accessory pathway is the one will come have a concentric atrial activation on the septal ATs. So these are the three main DDs when you have a concentric atrial activation. So you do VOP when there is a tachycardia is going on. We pace the ventricle at 10 to 40 milliseconds faster than the tachycardia cycle time. First we have to see that the VOP, whether the V pacing has captured the ventricle. Next thing is whether the V pacing has driven the atrium to the same pacing cycle length. If the atrium is driven, then after stopping the VOP, after the stop V pacing, we should see that the tachycardia is continuing or not. If all these criteria are fulfilled, then you will go for the what is the response to VOP, whether it's an AV or an AAV response, and you look at the intervals. This will come in the future slides. So in AV NRT, when you the tachycardia, you know, is a antichrony is one of the AV nodal pathways. Here I will represent the slow AV nodal pathway, and retroclavium is a fast AV nodal pathway. It can be in the other way also in atypical AV NRTs. So when you pace from the ventricle, first it captures the ventricle, then it goes in the engage the His-Purkinje system, then it goes in the His region, then the circuit, and so engages in the go retrograde via the here in the fast AV nodal pathway and depolarizes the atrium. When come to the post VOP response, when the last V pace beat captures the ventricle, goes engages the His-Purkinje system, goes to the His, and then goes into the circuit in the autotromic wave from the circuit and depolarizes the atrium, causing the A. Then it comes via the slow AV nodal pathway to the His and then to the V. So the response we get is a AV or a AH response. Some people also call it as VA-HV response. So in AV NRT, post VOP, we get a AV or a AH response. So this is a tachycardia going on the right side, which is about 270 milliseconds, and we are pacing at 250 milliseconds. With the pacing spike, every pacing spike, you see that the QRS is wide. So we have captured the ventricle. And next thing is whether it's A also driven at the same cycle length. So you can see this is slower. Eyeballing this, you can see that this AA interval is longer while this AA interval is short. So we also driven the atrium, and this is the last paced V which has gone to the A. Okay, so this VA, A followed by His and the V, AHV response is same. In AVRT, the circuit, you know, antichrony was the AV node and retrograde via the pathway. When you pace from the ventricle, it captures the ventricle, and via the accessory pathway it goes to the A and then comes down via the AV node and to the His and the His-Purkinje system. So there is something called, usually when you pace from the ventricle, usually the circuit get attacked both by the autotromic wavefront which goes along the circuit, and this pace we also can go in the opposite direction of the circuit, which is called as the antidromic wavefront. So this collision in AVRT can occur either in the ventricle or in the conduction system, maybe in the distal conduction system or in the AV node level. So in a post VOP response in autotromic AVRT, last pace V captures the ventricle, goes to the atrium via the pathway, depolarizes the atrium, so you get an A, then comes via the AV node, causes the His, and then it comes to the ventricle. So you get a AH response or the AV response. So both in AV NRT and AVRT, autotromic AVRT, you get a AV or a AH response. So this was a tachycardia going on at 300 milliseconds. We are paced at 270 milliseconds, and what this is the last paced V. This comes to the A, H, and V. So you get a AHV response. In atrial tachycardia, when you pace from the focal atrial, when you pace from the V, it goes to the His-Purkinje system and overdrive suppresses the AT. Ideally, it should not be called as entrainment. So our last paced V beat suppresses the A and causes the A. Then the next beat from the, it comes from the tachycardia A. So the tachycardia A depolarizes the atrium, then comes to the V. So what you get is a AAV response. Then comes is something called as a pseudo AAV response, which you find it in atypical AV node or decremental conducting accessory pathway, where the conduction from the retrograde limb is slow. So this is during the tachycardia we given V pacing. This V leads to this A, and this is the last V pace beat which gives later this A. So if you eyeball, you see that this V is followed by A, then this A, and then V. So eyeballing we say it is AAV response, but ideally we should look at the what is the last entry in A, which is this. So if you see VAV response is the proper electrophysical term. So it is seen in VA interval with more than the pacing cycle and is seen in atypical AV and rarely in decrementally conducting accessory pathways. So here you can see that by eyeballing you see it as V is followed by A, HV response. But if you see that tachycardia is at 300 milliseconds, when you pace at 280 milliseconds, this is the last tachycardia, paced V entering the A. So V, A, HV response. So this is another scenario. You have paced the V, but you can clearly see that the atrium is atrium and pacing spike to the atrium is varying, and this is very the tachycardia atrial tachycardial cycle length atrium is not changed. So this is actually we have not driven the atrium. So actually V is when you are pacing from the V, the atrial rate is going at the tachycardia rate. So it's a VA dissociation is there. So this rules out AVRT, AT and AVNRT is still possible. So in VOP response, in a nutshell, if there's an AVNRT or AVRT, you get AH or AV response. If it's AT, you get AAV or AH response, and always be aware of the pseudo AAV response. Coming next to the intervals. So post pacing interval is the time taken from this pacing to go into the circuit, complete the circuit and come back here. So in case of autodromic AVRT, the post pacing interval will be the tachycardia cycle length plus twice this time for going from here to circuit. While in AVNRT, it is tachycardia cycle length is this one plus twice the time it goes from the pacing site to the His-Purkinje system to this. So hence you can clearly see that the post pacing interval will be shorter in autodromic AVRT when compared to AVNRT. And other important thing is, since we are pacing faster than the tachycardia cycle length, V going to the A can cause a decremental conduction in the AV node. Since this decremental conduction during pacing can spuriously increase the PPA for the PPA. So this we should be aware. This is not due to the increase in tachycardia, it is just increasing the AH interval. So this should be considered when the AH interval after the last paced V is more than that of the tachycardia AH interval. Studies have shown that the PPA minus TCL of less than 115 milliseconds favors autodromic AVRT. Now coming to the stim to A interval. In AVRT, the stim to A interval and the V to A interval are nearly similar because they both are active. V to A is activated in series. So less than 85 milliseconds favors AVRT. In case of an AVNRT, VA interval is pseudo interval because V from the lower turnover point V is activated, from the upper turnover point A is activated. So both can be active. V and A are activated in parallel. That's why you get a pseudo interval. It's a pseudo interval in AVNRT. In while during pacing during the pacing, it's SA interval. SA interval is from the stim to the A, which is a true interval. So SA interval minus the VA interval is less than more than 85 milliseconds in AVNRT. So another caveat is in autodromic AVRT, if you have the pacing site is far away from the circuit, either is a left sided accessory pathway or it's as a decremental conducting accessory pathway, the post pacing interval may be very long. This should be kept in mind. So this is a patient, tachycardia is going on, we have paced at 270 milliseconds and the post pacing interval is 390 milliseconds. 390 minus 300 is 90, which is in favor of AVRT. And also you can see the stim to A, it's 120 and 126 and VA interval is 115, the difference is 10 milliseconds, which also favors of AVRT. Okay, this is the final slide. So when you do a VOP response, first make sure that the V is captured, V has driven the A, and after stopping V, the tachycardia is continuing. Then look at the VOP response. If the VOP response, you get AAH, you roll out a pseudo AH is rolled out. If it's not pseudo AAH, then it's atrial tachycardia. If the response is AH response, then you look at the intervals PPA and PPA minus TCL and SAVA SAVA. If it's a more about a prolonged, it favors AV and RT. If it is less, it favors autotromic AVRT. Thank you. I have not spoken about other manners in want of time. Thank you, sir.
Thank you, sir. Thank you for the excellent talk. Now I would like to invite the next speaker, Dr. Sam Asirvadam, sir, who is a consultant, Division of Heart Rhythm Services, Department of Cardiovascular Medicine, Chair for Education, Division of Heart Rhythm Services, Department of Cardiovascular Medicine, and Vice Chair for Innovation, Mayo Clinic, United States. Over to you, sir, on the difficult accessory pathway ablation.
Thank you very much. It's great to be here. I remember 2020, I think Dr. Murali was trying to organize this meeting. We kept postponing 1 week, 2 weeks, 3 weeks, waiting for COVID to go away. And now 4 years have gone by. We're here, but some things don't change. We still have the enthusiasm to learn about heart rhythm. We see this expertise has grown so much locally. And we can see general cardiology questions also, what to do when somebody comes back with failed ablation. So some things haven't changed, and we'll try to talk about some topics to integrate with the meeting today. So difficult accessory pathway ablation. So few things. You can get difficult ablation because diagnosis is wrong. It was not a pathway causing the tachycardia. It can be an unusual tachycardia, unusual type of pathway, or it can be, it's difficult to ablate because of its location. Most of the time, this will be the 3 reasons for difficulty. So let's talk a little bit about each. In our mind, we have to remember accessory pathways always take path of least resistance. Wherever atrium is close to ventricle, more likely you are going to get an accessory pathway. So if it is on the annulus, mitral annulus, tricuspid annulus, almost any location you can get an accessory pathway. In the center of the heart, because the aorta is occupying the center, it separates atrial tissue from ventricular tissue. So less common pathways, they can occur, and they often involve the aortic annulus, and they can be ablated in that location. We have to anticipate when there is pre-excitation where we are going to ablate. Anybody who is practicing electrophysiology out of fellowship, when you look at WPW ECG and then you compare where you were successful with ablation, should not be more than 3-4 millimeters difference. It's a very important skill. Many different algorithms, you don't even need algorithm, you can intuitively analyze. But if you have to learn one criteria, I suggest Jackman criteria, Aruda-Jackman criteria, mainly because it was developed and then tested prospectively. Very few algorithms have had that systematic testing for validation. Important thing when you're looking at any algorithm is delta wave when you analyze, is it positive, negative? Most important is that first 40 milliseconds. After that, it can just fuse with the R wave and can confuse you. Look at the first 40 milliseconds to tell positive or negative. Negative in a particular lead means pathway is close to that lead. Lead 1 negative delta wave means left sided, close to where lead 1 electrode, positive electrode is being placed. I'll hit some high points to avoid difficulties when you're using this Aruda algorithm. First is you have to tell yourself, is it left free wall or not? Because left free wall generally are not difficult pathways. So left free wall, any of these criteria, it's left free wall. If lead 1 delta wave is negative, lead 1 delta wave is isoelectric, or if V1, the R wave, not delta wave, the R wave is positive. If R is more than S in V1 or delta wave in lead 1 is negative or isoelectric, it is a left free wall pathway. If these 3 are not seen, any of these 3 are not seen, so R is small in V1, lead 1 delta wave is positive, then it is either an epicardial, septal, or it is a right free wall pathway. For epicardial, the most important thing is lead 2. Lead 2 is completely negative. Right from the start, it's negative. That means the tissue being activated first is on the outside surface of the heart, closest to lead 2 electrode on the feet. No chance for any intramyocardial activation. So good to just eyeball lead 2, see completely negative. So now once you know not left free wall, not clearly epicardial, you want to know septum or right free wall. Best criteria is look at V1. If delta wave is not positive, isoelectric or negative in V1, and then flips and becomes positive in V2, that's a septal pathway. If it is already positive, the delta V1, if it's already positive, no matter how small positive it is off the septum. So very important just to avoid kind of difficulties because we were mapping the wrong site. So 2 areas. So this is one that you should get your mind used to. Look at lead 2, completely negative. So completely negative, you're thinking this is epicardial connection. Epicardial can happen in multiple sites, but it's usually a left lateral epicardial, posterolateral epicardial, posterior or posterolateral, and you'll ablate in middle vein or in a posterior lateral vein to be successful in that case. I'll talk a little bit about that case. If I think back of my career, most common misinterpreted ECG is this one. It happens very commonly all over the world. Somebody will look at this and they will say, this is very tall delta wave, 2-3 AVF, so anterior, maybe septal, this is near the His. You may record little bit His, but this is not a septal pathway. And the reason it is not septal is delta wave is already positive in V1. So it's very important because your way you hold the catheter, you should not focus on torquing onto the septum. You should release that clockwise torque and try to push up anterior. Maybe you will still see little His, but you will not be on the septum. There is no risk of damaging the conduction system with this pathway. Unfortunately, this gets misinterpreted. Then you get contact onto the septum, falls back, sometimes gets inadvertent conduction system damage. One word about diagnostics as a result of misinterpretation. You have to be able to see the His. That is the most important in the PVC to start during tachycardia. If you see the His, then even very early PVCs, you can compare, did I move the His? How much did I move the His? And did I move the A more than the His? If I move the A more than the His, it is an accessory pathway. So it doesn't have to be His refractory. You can engage the His, but if you move the A more than the His, so have to be able to see the His. How do you see the His? Don't put the PVC at the apex. Put the PVC at the base. If you put at the apex, you won't see the His. It will be fused with the V. Put it at the base, somewhat near the His region. V will be captured first. His still has to come through the conduction system distally, so it will be seen little bit later. You can identify very well. Very important to be alert to when you put PVCs and you're not engaging the His. If the A is delayed or the A is blocked, no A, termination of tachycardia, that is an accessory pathway. One difficult type of accessory pathway is pathways that tend to block decremental, diseased, delayed pathways. PJRT, Epstein anomaly. In these cases, you will never pre-excite the A, and you will spend an hour trying to make the diagnosis. But when you see the post-excitation or the block, you have got a diagnosis. Your ablation will target pathway potential on the annulus. Word about parahesian pacing. Everybody should do this maneuver as part of routine EP study to get practice and understand the nuances. Parahesian pacing is a method to diagnose activation sequence in the atrium. That means you will pace at high output and low output. At low output, you capture only ventricle. At high output, you capture the ventricle and engage the His as well. Then you look to see when you are capturing the His, QRS is narrow. When you are releasing the His, QRS is wide. Then you look at the activation sequence. How did that change? If it didn't change at all, it means you have only one way you go from V to A. That's point number one. If the activation sequence changes, you have got two ways to go from V to A. So you have AV node and pathway and pathway, or multiple pathways. So first step is the sequence the same. Second is when you release the His, if you get longer interval, that is AV node dependent. So this sequence is AV node dependent. It doesn't exclude a pathway, it doesn't include a pathway. It tells you this sequence, if this is the sequence of your tachycardia, that's an AV node dependent VA conduction that's relevant for that tachycardia. If the sequence changes, you have to repeat the parahesian pacing to know that second sequence, whether it is AV node dependent or pathway dependent. Most common cause of confusion is failing to appreciate parahesian is not a way to diagnose a pathway, it's a way to diagnose a mechanism of atrial sequence when you pace from the ventricle. So some points about locations and ablation of pathways. So pathways are on the annulus. So you will ablate on the annulus. Very important. You don't ablate ventricular insertion, atrial insertion. You ablate on the annulus. The annulus, the signal you will see is some V, some A, and the pathway potential. Pathway potential, if recognized with contact, the most difficult pathway ablation will be successful. So we'll spend a little bit of time with that. First thing to remember with pathway ablation, especially for those in training, residents, fellows, ignore the VA and AV time. Ignore the VA and AV time. The VA and AV time can be very short even if there is no pathway. It's a pseudo interval. You pace the A, there's no pathway, you look in the CS catheter. By chance, the A activation and V activation via AV node reach at the same time, you will think A and V are fused. So least important is how close they are coming together. In practice, this is very commonly used. It will work, but when you have a difficult case, you will be challenged. So learn the skill of how not to rely on the AV or VA interval. So what to use? The ideal is to use the pathway potential. So what is pathway potential is, the pathway itself is electrically active. So when electricity goes through this muscle, it generates a signal. And that signal is distinct from the neighboring ventricle and neighboring atrium. The pathway potential, if you are recording, you are very close or right onto the pathway, contact and ablation at that site will be successful. One of the problems why a lot of even experienced electrophysiologists don't rely on this as a target is because it takes little effort to know this is the pathway potential. But if you're still in training, your habits are still forming, try to make this a habit. 5 minutes initially will take you 15-20 minutes. After your first 100 cases, maybe 5 minutes, you will recognize, you will get contact, and you will ablate. The thing to keep in mind, what makes it confusing is, this signal that's in between A and V during pre-excitation may be part of the V, may be part of the A. And this you have to distinguish between really this is pathway potential. simple way is to think, if this is part of the A, if I just pace the A little faster and block in the pathway, I paced the A, pathway blocked. That signal disappeared. If it was A, why will it disappear? As long as I capture the A, it will still be there. So if it disappears when you block in the pathway or lose AV conduction, it's not A. And as long as it's not A, it's either a very early V or it is a pathway potential, and you will likely be successful in ablating at this site. If you are a purist and you want to be sure this is not part of V also, while you are pacing the A, you can pace the V and show that you can move the V, and this pathway signal, this signal of interest, stays in the same location. So if it's not A, it's not V, and you're nowhere near the His, the only thing it can be is pathway potential. That is your target. Now, second concept for difficult pathways that's good to have in your toolbox is understanding the slant of the pathway. Why is this useful? If pathways are not a dot, they are a muscle band. If they were a dot, there's only one place you can ablate. If it is a muscle band, you have little choice. Why do we want the choice? Maybe in one end it is too close to AV node. Maybe in the other end it is too close to the coronary artery. So we can understand that if this pathway is slanted and we know where it is safer to ablate, we may have an option in some difficult ablations. Pathway slant is a concept once understood you will remember and do in all your cases. The idea is annulus is in one direction, pathway is not perpendicular to the annulus, it is slanted. That's the key concept here. Now, what this means is if you pace the V at two different sites in a retrograde pathway, or A at two different sites in an antegrade pathway, the AV and VA times change. Accessory pathway is conducting from A to V. Why should it depend where you are pacing? Local time should still be the change. That was the early thinking. But it changes because of the slant. So imagine this pathway is slanted like this and we're recording in this electrode. If we pace in this direction, by the time the V is recorded, already you're getting to the pathway and getting to the A, so VA is short. On the other hand, when you pace in this direction, you reach the V, then you have to wait till you find the pathway, go across, come from the A to record an A, and it is longer. So VA short, VA long. When you pace along the slant, close to the ventricular insertion for a retrograde pathway, that is going to be a shorter VA. So this will tell you how it is slanted. V is nearer septum or V is away from septum. What do you want to avoid? Where you want to put your second burn? Simple case, doesn't matter the slant. Difficult case, good to find pathway, good to understand the slant, and then you consciously take your best shot. Fluoroscopy for why sometimes pathways are thought to be difficult when actually it is quite simple. Pathway is on the annulus. So in RAO projection, that's your catheter orientation. CS catheter is showing annulus, electrode is on the annulus, straddling, going from A to V, little bit more on the V side. LAO view, this is a bad location. Why? Your catheter should never be in the LAO in the same plane as the CS. You cannot be on the annulus with this type of LAO. What you want is some separation in the LAO. So RAO you want to straddle, LAO you want some separation. What is the reason for that? Is because there is thickness of myocardium and the annular tissue that separates the CS, which is outside the heart, and your catheter, which is inside the heart. If it is touching, that means you're atrial. You're just pushing the atrium to try to reach towards the CS electrode. Simple pathway can be made difficult by not having the optimal positioning of the catheter. When you ablate from underneath the mitral valve, you will never be close to the A. Very important. Your stable location, if this is where the pathway is, you will record big V, you will record pathway potential, but you will not record a big A, very, very small A. If you are getting a good A, you are not underneath the valve. So sometimes when catheter stability is difficult or you're doing retrograde aortic, you want to come underneath the mitral valve, don't expect to see the A. You should have mapped not under the valve and you ablate under the valve, not needing to see the A. This is an example, pathway blocked, hardly any A that we can see in that location. Difficult pathway may be because of bystander accessory pathway or bystander phenomena. What does this mean? It means there is two different things going on between V and A. One is a real cause of the tachycardia, culprit for the tachycardia. Other is just there, it is a bystander. For example, you look at this, during this rhythm, we are seeing 3 different atrial activation sequences. Same rate, but RA is very early, RA is late, septal A is early, septal A is late. What this means is there is a tachycardia going on, but there are more than one ways of connecting V to A. So this can be a difficult case because you will be chasing one sequence going from beat to beat, minute to minute, and you may fail in the case. Key is look and see what is constant. So what is constant here may be the early A in the CS region about this electrode is exactly the same. If that's exactly the same, whatever else is changing, probably that connection is the culprit. Target that, tachycardia will stop, then pace again to see if the other connections, where they are and are they relevant for other tachycardias, and choose to ablate. If you make a mistake and you didn't pick the culprit and you ablate, tachycardia will continue, but the activation sequence will change. What to do? Keep ablating, finish the burn, kill that tissue. Even though the tachycardia is not terminating, finish the ablation. Otherwise, when you come back to that site, there may be some edema and it will be difficult to put your catheter in a good contact to try to ablate. You just should understand what is happening and continue to finish the ablation. Another common cause of difficulty are pathways that are producing wide complex tachycardia, antidromic tachycardias. So if you ask somebody who is experienced 3-4 years and what is the tough pathway they were ablating, many times it will be some variant of antidromic tachycardia. So let's talk about some causes of difficulty. First, some terms. You'll use this word Maheim to describe an true accessory pathway AVRT down a pathway up the AV node producing tachycardia. What separates this from other AVRT is this pathway has AV node like behavior. It is decremental, slow conducting, and it never has retrograde conduction. So this unique properties make this a special type of pathway, and because there is no retrograde activation, you can only get a wide complex tachycardia, antidromic tachycardia. Contrast this to a much less common type of tachycardia where from the AV node, instead of conducting to the His, you can conduct separately to the ventricle or even separately to the conduction system. This is your nodovesicular or nodoventricular tachycardias. And then one which is actually not a pathway fasciculoventricular tracts that conduct from the conduction system towards the ventricle. Few words about handling this type of pathway. First mistake when you have this is mapping the early V. The early V is irrelevant for Maheim type pathways because it is just connecting to the conduction system. What should you target? You have to target on the annulus. Ignore the early V. It can be anywhere. It can be same as the right bundle. Target on the annulus. And when you target on the annulus, you will see a signal far away from the septum that clearly shows like a hiss-like signal. If this signal is identified, you're on the annulus and you have contact, this will be a successful ablation. Main mistake is trying to ablate the early V, and while you're doing it, coming closer and closer and closer to the annulus, and then having trauma, mechanical trauma with catheter manipulation in that side. So just one last comment I'll make about diagnosis of this antidromic tachycardia. It's very commonly mistaken for VT or bundle branch block. Key point is keep a catheter that's on the septum, pace from the free wall, and see when you pace, are you able to get to the V without even getting to the septal A. If you don't even reach the septal A, you cannot reach the AV node. That means you're going through a pathway. If that produces the same QRS and resets the tachycardia, that is this antidromic pathway. Remember, fasciculoventricular tracts, no need to map or ablate. They are just phenomena in the heart. Once you recognize there is no true pathway, you can just leave them alone. I think I'll stop there. Thank you very much for your attention.
I would like a question from Dr. Anand. Can the speakers come onto the stage to field the questions from the floor and the panel?
Thank you, sir. It was indeed a great academic feast, sir. So I would like to request the speakers to please sit on the stage for open questions followed by photo session.
Question to Anand. You mentioned that atrial ectopics, so it's usually concentric.
No, sir. In this scenarios where septal AT was the scenario where they were talking about. All the DDs
not all atrial ectopics. Okay. The other thing to Dr. Sam, if we are below the mitral valve and a left lateral accessory pathway, you were mentioning that even if the A is not visible, you have a good V which is very much early.
No, the V is irrelevant. So you have a retrograde conducting pathway VA. So you first mapped along the annulus your usual fashion. So there you found accessory pathway, you found it, but you're having trouble ablating there, maybe because of stability. That time you think, let me try getting underneath the valve. So you already know your spot. Then you put it in that spot, you will see V. You should still see accessory pathway signal, but you may not see any A at all or little bit A. So it's a technique for ablation, not for mapping. Same can be in the tricuspid valve also. For free wall pathways, you can come from left subclavian and get the catheter under the tricuspid valve. Very difficult way to map because you won't see much A and you cannot move the catheter well. But if you've already mapped, this is your way to ablate.
I have had some experience like that. That's what I thought. I'm hearing it that without A you can. I thought it was just an accident. Okay. Any questions from the floor?
Sir, I have a very basic question. Sir, this is regarding mapping of pathways and trying to map their pathway potential. So once we, as sir told that we first try to create an integrate block in the pathway and then see that potential is not part of A, and then we pace the V and then show that this is not part of the V, that way we are sure. So my question is where exactly to ablate in the V? So as we know that once we are, suppose we are mapping the pathway in the integrate way by pacing A. So once we change this sequence to V pacing, will there be any, what are the, will the V EGM also change by pacing now, because now it's going in a different direction. So I have this very basic doubt, I want such practical steps on it.
I'm not understanding the question. You're saying should you ablate during A pace or V pace? Is that
No,
the question?
no sir. So this question is regarding how to be sure once we are trying to locate the pathway potential. So we pace A, we are seeing some potential in between A and B, which we are doubtful whether this is pathway potential or not. Then we create antigrade block in the pathway and then show that this is not part of the A. So, but we are not sure at that point whether this is pathway potential or part of V. So then we pace the B. So that way we demonstrate it's not part of V, and then we know it's not, it has to be pathway potential. My doubt is where exactly to pace in the V, because that is the something which I am not able to understand, where exactly to pace, because we'll be changing the V sequence kind of thing.
Yeah, so first of all, two parts. If you have an antigrade conducting pathway and you see some signal and you think, could this be pathway potential? If actually it is V and it's very, very close, you can burn there, it will go away. What you won't be successful if it was just a late part of the A. So that you have to distinguish. So that you just put a PAC or pace faster block and you have shown it's not A, that itself is enough. If you want to separate from V, it doesn't matter where you pace in the V, but if you pace too far away, it may be difficult to show this maneuver. So just pace somewhere on the septum and you put the V earlier. You just have to move the V little early. So you're pacing A while you put the PVC. You move that V little early and look and see did that signal change at all. And what you'll notice is during A pacing, signal to V had an interval. Now when you put the PVC, that signal to V has shortened or become negative. That means this is separate from the V. You can be 100% sure. But this is more a maneuver just to be sure, that's all.
I had this doubt, sir, regarding suppose if we have a left lateral pathway. So once we start pacing, generally we have a catheter in RV. So the whole EGM there changed. So that way it becomes a bit confusing sometimes.
No, it should not be confusing at all. What you're looking at is timing, not quality of the electrogram.
One question to Dr. Yogesh. Dr. Yogesh, can you elaborate about Lewis lead? How to?
So actually, Lewis lead is to, in case of when the P waves are buried into the QRS, so we attach the three leads, that is like a right arm lead into the manubrium, left arm lead onto the fifth intercostal space on the right border of the sternum, and the left leg lead onto the right intercostal space, and the right leg lead will be on the same place. So this will give, so in case of atrial fibrillation or in case of atrial tachycardia, the atrial, it will enhance the amplitude of the A wave, so we'll get more information about the
It's for the fellows to know how to place Lewis lead. I asked this question. And also one more thing, the ST depression AVRT, does it tell us about the ischemia or it's just electrophysiological phenomena? In TMT, we say if there is ST depression V5, V6, you say it's ischemia. But during the same thing is there is tachycardia and there is ST depression which is more than 4 or 5 millimeters. Can we take it as a risk factor or a ischemic thing, or it is just an electrophysiological phenomenon?
I don't think it is a ischemic phenomenon, but what I have read from the previous studies which they have described is related to only the VA interval, and as the pathway is conducting and taking more time for the atrial activation, so that the P wave activation is superimposed on the ST segment, and that's why that getting more depressed. So I don't think it is due to ischemia.
That would depend upon the age and the other comorbidities which the patient has. if the patient is in the coronary age group, has comorbidity, if somebody has an ST depression, especially in the example you showed, V5 and V6 had a flat ST, you should rule out ischemia. There are patients who have complained of ischemia while we were doing the angio, doing pacing maneuvers. We have done angiogram subsequently and found the block and done a PCI for them. So that should not be ignored.
I totally agree with you, sir. And the thing why I am agreeing totally is that ST depression was there in the TCG, sir. And I remember clearly that in AVR also there was little bit elevations were there. So I think definitely any patient is there, we should look for the ischemic thing. I think I 100% agree with it, sir. And my one more question is that, sir, in case of left-sided pathway ablations, like we had patient who had left-sided pathway ablations, in the case of the pediatric age group, like around 14 years, which we usually in GH, even if it is 14, we keep it in our medicine only. In that patients, whether you give anticoagulation or with no comorbidities, left-sided pathway ablation was done with WPW. In that patients, whether you prefer anticoagulation or not.
Generally, we'll prefer only ecosprin for 1 month. We don't give anticoagulation for prolonged time. Only 1 week ecosprin.
Thank you, sir.
One question to Sam, sir, actually. Your approach towards ablating an anteroseptal pathway and your approach towards achieving stability in the right free wall and your approach towards epicardial CS pathway, ablation approach.
So we'll go through each of these scenarios. So anteroseptal. So really this is true anteroseptal means you have near field His, you're on the septum. So you've clocked on the septum. You cannot clock any further. And you're as high as you can possibly go without leaving the septum. So you're clocked and you're as high as you can possibly go. Near field His is present. So if you're truly in this location, the risk of AV block is very low. It's very difficult to ablate the His bundle. If you have ever tried ablating His bundle tachycardia, you'll see it's very difficult. It's an insulated structure. So if it's near field His and you have the pathway potential, catheter is stable, you can ablate. If you have cryo, always good to do cryo first, just for like medico-legal issues. But if you don't, I would be very comfortable ablating with radiofrequency energy. The near field His anteroseptal is actually low risk. The only time you will get in trouble if catheter is not stable and it slips down, so slips down like a diagonal and comes to mid-septal region, then you can get AV block. As long as catheter doesn't move, you will be successful. To make it little bit more safer, you can move slightly into the ventricle and put more upward pressure on the catheter. So you actually move septal and then take your sheath and catheter and push it up a little more. So if you do this, even if it slips, it will slip up, it won't slip downward, and you have almost zero chance of AV block. Now second question, the one other question that you had was about stability for free wall pathway. Right free wall, because of shape of tricuspid valve, very difficult to keep the catheter stable. So you have few methods. Big change is using sheaths. Big change. Before the first sheath, short sheath came, this was nightmare to get stability. Once you have the sheaths, you find the correct sheath, you will get it there. So right side, if you have this curved sheaths, if it is anterolateral SR1, straight lateral SR2, posterolateral SR3 sheath. Agilis sheath or deflectable sheath can be made to look like that, and you get that stability in that location. That is the big difference. Second is, despite the sheaths, it can be tough sometimes, and there you can go under the valve. How to go under the valve is you have to take the catheter into the V. Very important step. Once you're inside the V, move the catheter in 4 directions to make sure you are not caught on the tricuspid valve apparatus. Critical step. Once you know you are free in the mid-ventricular side, you curve the catheter straight onto the ventricle of the area of interest, then put a curve and pull back. And as you pull back, you will find that you're underneath the valve at that location. So why this is good is, one is stability. Second is, if you're near AV node like mid-septal, posterior to mid-septal, this is also good so the catheter will not come back to the A. Notice you cannot map like this. You should have already mapped. You're just stabilizing the catheter in this way to that location, and then you ablate there. Third is, you can use a second catheter to stabilize the first catheter. So you can either take a ring catheter, or you can take a second sheath and another catheter. And once you get the catheter, there's this location, you feel you're there but not getting good stability. Make the second catheter parallel to the annulus and push away to the lateral wall. That will keep the catheter in contact in that tissue. All of these can be tried, but really picking the right sheath is a big difference in getting the stability. 2 sentences about epicardial coronary. So epicardial coronary, once you've recognized, good to do coronary angiogram to see where the arterial system is. And then second is do CS angiogram to see is it a big diverticulum or just little bit dilation or normal CS. When you ablate, start ablating more ventricular. The reason is you will avoid this posterolateral branch. Second is that even if you fail, you can always come more proximal to the mouth of the diverticulum. But if you ablate at the diverticulum and fail and it closes, you won't have access more distally. So must get the arteriogram, good to get a venogram. Start ventricular, even if it fails, you can come back to the ostium and ablate at that site.
Last question, sir. Sir, as you mentioned about the slant, so you pace the different sides, you bring out the, you push the V or the A to look for the pathway potential. Once you've done a differential pacing against the slant, does the site of the pathway potential, does it match where the earliest V or earliest A is, or they're completely different sites?
No, so that's the whole concept of slant. So you have your recording electrodes are not in the same plane as the pathway. They are not perpendicular, they are not parallel, they are at a slant. So at a given electrode, wherever that pathway crosses that electrode, that's where you'll get the pathway potential. But where that inserts into the V, that's where you will get the earlier V. Where it inserts into the A, if it's bidirectional, that's be the earliest A. So they will be all close together. It's not going to be from one site and 2 centimeters away, but it's not all being recorded at the same location. So the slant helps you to identify, especially if you pace against the slant, easier to see the pathway potential because the V and A are separated, easier to see, and then you get your ablation catheter to that pathway potential and ablate.
So you would advise that strategy in all cases, sir, upfront?
I am not sure what you're asking. It's all of these are techniques to map and ablate.
Thank you, sir.
Thank you, sir. We have now came to an end of session 2. I request the chairpersons and the speakers to join for a photo.